Good afternoon, everybody, and thanks for coming to this special Dean's Lecture. For those of you I haven't met, my name is Mike Clegg. I'm Dean of the school. And we hold these very rarely for people who of note who come, and we want to make the entire school community available and also benefit from special speakers. And as you all know, our speaker today is Dr. Trevor Mundel from the Gates Foundation. And I want to thank him for coming. I also want to thank the contingent of people who came from Gates. And so first, Chris Karp, who's here, but he has another reason to be here in that he has a close personal relationship to the school. And Megan Carey, who's also a member of the school community, and Andrea Brooks. Thank you all for coming. And I want to thank Matthew Santosham, who's been instrumental in lobbying to get Trevor here. And we know how persistent Matthew can be. So Matthew, thank you very much for doing that. We appreciate that. We've had a long-standing academic relationship, collaboration with the Gates Foundation since it was created, essentially. And we have prospered and benefited greatly from that collaboration, both in terms of the quality of our work and the resources that they've given us. And I think all of us in this room know how important the Gates Foundation has been in driving the global health agenda. And we've been privileged to participate in that effort. Most of the funding from the Gates Foundation has come from the Global Health Program, which Dr. Mundel has led since 2011. As president of the program, he's directed the Foundation's work in research and development of health solutions, including vaccines, drugs, and diagnostics. He's focused on harnessing innovations in science and technology to fight diseases such as HIV/AIDS, TB, malaria, and neglected tropical diseases. His background is in healthcare. Before joining the Gates Foundation, he served as global head for development at Novartis, and before that, he worked at Park Davis, Pfizer, and Alkermes. A native of South Africa, he earned his medical bachelor's and medical degrees from the University of Witwatersrand in Johannesburg, and he also studied mathematics, logic, and philosophy as a Rhodes Scholar at Balliol College of the University of Oxford, and earned his PhD in mathematics from the University of Chicago. We're really honored to have you here today, Trevor, and look forward to hearing your thoughts. So please join me in welcoming Trevor Mundel.
So Mike, Matthew, thanks very much for this invitation to speak here today. I'm delighted to represent the Gates Foundation here with such a fantastic turnout. Particularly I see of likely many students, graduate students from Hopkins. As we were discussing last night, a group of us got together. The Gates Foundation has such a broad, deep relationship with Hopkins. Out of all the academic institutes, when I look at the set of grants, and the differentiation over here is not just grants from a purely technical academic research perspective, but very practical applied work in the field. You rank really as the #1 institution that we work with, so I'm delighted that we could have this dialogue which started this morning. I would like this presentation or this lecture series to be part of that dialogue. So not just that I'm going to tell you a couple of facts about Gates and how we look at the world, but that I could also get some feedback from you. And that's one of the reasons for coming here, is that I always look for these opportunities, particularly for young people who are interested in global health. How could we capture their imagination and get them to join us on this mission and show them that there are pathways into this world which you may never have suspected. And then in the other aspect, which is in this time of straitened financing for some research, one opportunity that we've seen is there are often fantastic groups that have somehow fallen out of some of their primary directions, and we want to invite them into the home of global health and say that there's an alternative funding stream over here. There's an alternative contribution, in some ways a greater, more impactful contribution you can directly make. What if you want to turn a little bit in your research to some of these very applied problems that we have in the world? With that, let me make one disclaimer over here. So Niranjan Bose, who works with me and the group at Gates, we were talking about this title, and we used this title actually in a blog that we have called The Impatient Optimist. And we decided to do that to just pull people into that blog and get people to read an article we wanted to write around innovation. And actually, it had a dramatic effect over there, and a lot of people came in. A couple of them left comments which said that it seemed somewhat deceptive because we didn't quite understand why the title connected with the content of the talk. So that's a little bit my disclaimer over here. And hopefully people won't want me to continue and complete the joke, but that may well come up. We start with our equity agenda, which I found has had just tremendous resonance with people wherever I've gone. And this is a community center that I visited in Chennai a year or so ago, which was around our Avahan or SHIELD program in the HIV program in India, which I think was actually quite instrumental in nipping in the bud a brewing epidemic. And this is a community center for female sex workers and transgender individuals, which really was a refuge in a community and society that was not very accepting. And it continues today. Some of the types of interventions which I've loved to be able to go out and really try and understand in the field. Just in terms of how we structured, it may seem quite complex from the outside, and there are all these organizational constructs that are put in place. But essentially, we have two global programs. Global Health, that's my program. Global Development, my colleague Chris Elias heads that. And the focus on education, particularly in the US. And people say, well, what's the distinction between global health, global development? Well, there's one clear distinction. Areas such as agriculture, water sanitation, health, financial services are in the global development program. And we've also put some of the health programs in global development where we have a very strong focus on implementation in the field, like the maternal neonatal child health program, where we're very focused on delivery, for instance, in Bihar, Uttar Pradesh, in India. So the global health programs, though, and I'll go into some of the main areas of focus, remain end-to-end programs for us. So we don't have a conception of there's a product development or there's an intervention development stage. We're thinking about things from research right through to actual delivery in desperate communities around the world. And as we were discussing earlier today, for us, developing any new intervention starts off with understanding the community and the particular patient journey that would come into a level 1 clinic in rural Africa, for instance. And it ends with us being able to successfully introduce some significant intervention into these communities. It is not focused on a strictly research or product development or regulatory basis. I put this in, and I wanted to do a little bit of a Rorschach test over here in terms of these areas. So each individual area we're involved in, HIV/AIDS, we could spend a long time. And one around all the things that we're involved in, from male circumcision to all of the delivery aspects, the PrEP programs, that could be a very long list. And what I've tried to do, and one of the issues that we have ourselves, is a matter of focus. It's very easy to get so distributed across so many areas and have a little bit of seed funding everywhere that you can't really do anything significant. So continually we come back to our groups and challenge them. Well, how about in the next year or two, what are the two most important things that you're going to be doing for global health? Try and focus. What are those things? And let's see that the flow of resources go predominantly to those most important things. So as we run through this, we have a few of our colleagues over here. They can test me in terms of have I remained consistent with my view of some of the priorities in these areas. I'm just going to mention them. And if you have further questions, we can discuss that in the Q&A part of our discussion. And I'm also just giving an idea of those parts of the world that are predominantly our focus, which remain sub-Saharan Africa and South Asia. There may be a little bit of distribution, and within those regions, there may be some differentiation, but largely, we are working in sub-Saharan Africa and South Asia, and we could go into the reasons why that is. But we remain very focused on HIV/AIDS. It's our largest program amongst the particular disease programs. Such hopeful things happening now in terms of the neutralizing antibodies. Will we have a vaccine based on those neutralizing antibodies? A huge area of investment for us, and some of the long-acting drugs that I think are going to have a huge impact. So we see this epidemic, which continues unabated, particularly in Southern and Eastern Africa, as really requiring some real innovative thinking and potentially some new interventions, and clearly a much better job of introducing things like male circumcision, which is certainly better than any moderately effective vaccine, where we see the first indications that there's some traction and we're starting to scale up in our delivery of that, particularly in South Africa. I should say Southern Africa, it's more broad than that. Tuberculosis, which from my perspective is one of the most underfunded areas of global health. You know, the 1.4 million deaths, the size of this epidemic, and the frightening prospect of the drug-resistant tuberculosis. Even ourselves, I find it differentially within our programs as potentially underfunded. Difficult prospect for a TB vaccine in the near-term future. So the action here is on drugs, which look quite hopeful that we would have more effective regimens. The barrier to having impact when you have either a 6-month regimen or an 18-month regimen in the drug-resistant form of tuberculosis is really high for developing countries. And this is where I think we're going to see rapid progress in the next couple of years. Malaria, these are the 3 big entities that we focused on. We had a lot of discussions. Hopkins is very involved in malaria research from many different aspects and a very important contributor for us. Malaria now is all back to the eradication agenda. To the extent in 2008, Bill and Melinda had talked about their hope for eradicating malaria. In some ways, we were ducking and weaving the real issue in the last couple of years because it wasn't clear what the strategy was. We have a new director, Alan McGill, who's come in and has been working with the community to find what I think is a really innovative new malaria eradication strategy, which involves basically the fact that the problem with malaria is not so much the few people or few percents of people who actually get very sick, which is a bad problem. It's this vast asymptomatic reservoir. So you've got to get parasites out of people en masse. And the strategy is potentially a mass drug administration strategy, which is just enormously difficult to think about when you think of the breadth of the malaria epidemic. So we need all of your keen insights in order to make this fly. Neglected infectious diseases, which in some ways have taken a backseat to the first 3 entities over here, but you're going to hear about some news coming out in the next couple of weeks, which will be significant new funding. You'll hear about also the progress that's been made. We had this London Declaration 2 years ago where a number of the major pharmaceutical companies that have been producing drugs, the effective drugs actually, like albendazole, like ivermectin, for these neglected infectious diseases, basically committed to removing the supply problem, the drug supply problem, so there would be enough drugs to treat everybody who would need it. And that actually has come to fruition on the supply side. What has hampered us is that we have been very incapable of actually delivering these huge supplies via the supply chains that we have. And if you think about the logistics of some of these programs, if you aggregate the mass drug administration, it's mind-boggling to me, but we are trying to reach, and we have been reaching, of the order of 700 million people in mass drug administrations every year. And I think the scale of such an enterprise, and we need to scale that up actually even further in order to, and what our goal over here is to eliminate and get rid of some of these hugely vexing diseases in particular areas, particular populations. Most hopeful about the situation with sleeping sickness, human African trypanosomiasis, where we have some, I think, very good strategies that we potentially can go the last mile and have an impact over there. We'll get to a lot of the work that's been going on around the enteric and diarrheal diseases. Once again, as I was looking through the topics that I wanted to cover with you, and I've been talking about our innovation agenda in global health with a number of audiences, I did want to put it in the context and look at it through a Hopkins lens. And that was very easy because so much of the work actually is with you. Talking with David Sack earlier, very exciting work going here on this, the diarrheal diseases front. The rotavirus vaccine, which we'll discuss a little bit, is going to be pivotal. Matu has been hugely involved in that program. Pneumonia, which continues to be the #1 cause of mortality in children under 5. And this is a story, once again, of the pneumococcal vaccine. Right now, which is effective in its conjugate form, but not widely deployed in developing countries. And just to give you another perspective on what the issues with the pneumococcal vaccine, this needs to be deployed. Currently, out of the basic package, the Gavi package, which we're looking at, which would be the pentavalent vaccine, the rotavirus vaccine, and the pneumococcal vaccine, it contributes about half the price. It's about $20 now to give that basic package. Half that price is in the pneumococcal vaccine. And every dollar we can actually reduce that and maintain the quality and efficacy of the vaccine is a huge saving to Gavi. The next vaccine that's in line, that's already being deployed, but the deployment has been slowed because of the availability of funds, is the HPV vaccine. So what a travesty to the extent that we couldn't have both of them, which is one of our big focuses on how we get a cost-effective and high-quality pneumococcal vaccine for broadly deployed in developing countries. Polio, I think everybody is aware that we're in the end game here, and it is a tough end game. And it's actually going to presage all the end games that we're going to get into, because how do you maintain the focus and the funding of the world when you're down to the last few hundred cases? You have a situation in countries where health ministers are having to decide about their scarce resources, and they're looking at massive health inequity and problems and are questioning, well, why should we invest in the last few hundred cases of this entity or that entity? But we have now, I think, a very solid plan for the final eradication of polio. We left with these 3 countries, essentially. You've heard about the spread of the virus to other areas, whether it be the Horn of Africa, whether it be in the Middle East, in Syria, and even the circulating poliovirus in Israel. But the truth of the matter is that these are the sources, so far, of all of that wild-type polio virus. So if we can eliminate these sources, then we will have achieved eradication. The plan is there. It's not going to be inexpensive. It's going to be of the order of $5.5 billion. And the timeline runs out to 2018. But it's now a realistic plan, and it's up to us to execute that. It's tough in the field, and I'll show you some of the tools that we've had to go with, which I would never have speculated would be part of a elimination campaign. So we get back to this question: do we need innovation in global health? And I would suggest that the numbers support that we do. Tremendously hopeful the fact that between 1990 and 2012, we basically halved the under 5 infant mortality. There are some residual problems, and we were just talking about the situation in Bangladesh at one of your surveillance sites over there, where exactly this phenomenon is found. Maternal mortality plummeted, but neonatal mortality has been much more resistant to change over the same period, and now constitutes about 40% of the total mortality in the under 5 group. So there remains this residual huge problem. And most frustratingly is that a lot of that problem could be addressed by existing interventions. That's what is a constant frustration to us. So if maybe the evidence is there strongly that there's a residual problem, a huge problem that needs to be addressed. The case that I haven't made is why innovation? Why technology? Why not just better delivery of these existing interventions, which obviously worked in developed countries? Well, some of the problem is, well, the major part of the problem is that we are often dealing with broken delivery systems. And those broken delivery systems are indeed improving. And there's a lot of work with general development. Those will, over the next couple of decades, improve. And we may get to circumstances where we can harness them. But for the next while, we are faced with very broken delivery systems. And what I've seen, contrary to my expectations, is that in the context of these broken delivery systems, the hurdle for what are effective interventions are much higher. So some of the solutions where the competency of the delivery system capabilities can actually transcend a complex therapy, a vaccine that requires multiple dosing and boosting, that has to be stored at minus 20 degrees, those can be effectively deployed in the developed countries here in the US. They cannot be deployed in developing countries. And it's very much when I started with Gates, I thought, well, we need to think about simple solutions, and we'll just deliver them, and it should be simplicity, and what exists should be the main focus that we have. And what I've actually come to understand is that the other aspects, the GIS mapping and satellites and cell phones, as much as I initially believed those really don't have a part of this world, have become quite central to how we're thinking about global health. So just before we jump into some of the examples of that, I did want to get straight with you and align on what we're talking about in terms of innovation. So as I say innovation, people often think, well, that's product R&D, that's research and development. And it is actually not just that. So the fact that more than 50% of Gavi's vaccines are supplied now by developing country vaccine manufacturers has been a particular intervention in that market, which has changed its dynamic dramatically and changed the cost structure. The multinationals have been big players over there, but they do not have the cost structure which has been really supportive of the vaccines that we can widely deploy to hundreds of millions of people. The consequence, 370 million children immunized with that massive increase in Gavi funding and the source of those vaccines. You get a lot of funding, you don't actually have the vaccine. Cholera, we have a great vaccine, we just can't make enough of it. We got 2 million doses and many million more cases. But in this case, we've been able to address, at least for some of the basic vaccines, that supply constraint. And not only immunized, but with a very significant drop in cost. And my favorite example of this is the rotavirus vaccine. So 2009, $7.50 a dose. Working with largely the multinationals, we went down to about $2.50 in 2012. And one of the most exciting projects, if not the most exciting project we're working on, the one that Matu has been intimately involved with, the rotavirus vaccine being produced now in India, they are committed to producing this for $1 a dose. And the efficacy results we've had actually look on the high end, if not better than the multinational vaccines in the context of developing country kids. So being able to introduce this $1 a dose vaccine is going to be transformative for Gavi and for kids in India and elsewhere in developing countries. Let me turn then to some of these innovations and why I have made this claim, at least, that we need more innovation in global health. Well, on the scientific side, we see a lot of challenges, and it's very clear with the vaccine front of the enteric vaccines. We have kids who have a high burden of pathogens, and it seems an altered microbiome, and difficulty in responding in the same way as kids with good degrees of sanitation and water supply. We see a decreased response, so we're looking for ways to boost those vaccines, and there's some very hopeful new adjuvants which are coming out. We may see these kids very infrequently in their lives. If we can touch them just once in their first year, that may be a lot. So we would like vaccines that are effective with a single shot. We would like those vaccines then to persist for a long time. And also because it's very difficult to give kids multiple shots at the same time even. We need to have useful combinations of vaccines as well. We also need vaccines that can remain stable. We'll talk a little bit about that for many, well, even for more than a year or more in the setting of environmental conditions that are very harsh. Talking a little bit about this further, I'm putting up a slide over here, which actually I would never put into a general presentation like this in normal circumstances. So it's a slide from the arcana of product development and how we think about the different phases of product development. So the reason for putting it in, because you've come up with something that is exactly in line with what we're talking about, this shift to the left. So if I explain what that means, this curve over here is the probability of product success. And let's say it's in the vaccine space over here. And where do we get that probability, average probability of success from? We look at the history of products and we look how they transition from phase to phase. And we have large databases. Our own databases, a lot of company databases are focused on exactly defining this probability of success. And if we think about what happens in terms of when that probability of success starts to rise, well then actually the rise shown over here, and this is my 16-second build slide, right? That's why you're not seeing the other critical part of it here. But what you see over here is that the rise in probability occurs around proof of concept. Now that's ideal. If we can have some fairly inexpensive way of knowing whether something new actually works, a challenge model for malaria, for instance, and I'll get to one of the other challenge models, where we can just take 20 people or 30 people and try the vaccine, and this is going to predict whether it's going to work in the field. If we can resolve that uncertainty early on in a cost-effective way, well, then we avoid going into these large studies, which may cost of the order of $100 million, and we really don't know whether this thing is going to work. And nobody has been able to put together a business model which is successful, where you take all this risk in your new vaccine into the late stages that costs hundreds of millions of dollars, and it's a real question as to whether this works. So this is the ideal circumstance. If the other curve had have come up, you would have seen that the current circumstance is that we are only resolving the risk up over here. And that is what I'm talking about in terms of shifting the current curve from here to the left over here. And the wonderful example that you generated recently is around the enteric vaccine, the vaccine for ETEC, where in a recent challenge study, and I'm fascinated, I believe that you're actually dosing a set of volunteers tomorrow morning. I would love to actually be present. This challenge model I've heard along the lines of the malaria model, but in this case, actually, these people actually volunteer to experience quite a severe diarrheal episode, typically. That is very reminiscent of the actual event in the field. And they are randomized to get the new vaccine or get a placebo. And the study has been with a very interesting new adjuvant called DMLT, double mutant labile toxin, which when added to the ETEC vaccine, which by itself was minimally effective, dramatically increased the effectiveness of this vaccine. So that's exactly the kind of new product that we're looking for, but it's more the process of imagine that we can actually understand whether this works with just 30 volunteers in a clinic, in a study which takes a few months. Well, you do have to wait, and you waited 6 months in the last case before you re-challenged them. But certainly something of much lesser dimensions than going out and doing a big field trial of people naturally experiencing diarrhea from ETEC, which would take us years, and we wouldn't even know that this worked or not, and you want to iterate. Usually the first thing you try doesn't work, you've got to change the dose. Imagine going back and forth like this with studies involving thousands of kids in a developing country setting. This is exactly an example of the shift to the left that I've been talking about. And here was the study which I've already mentioned. On the cold chain front, so undoubtedly, one of the big challenges we face is how do we supply, even when we have the drug supply in the infectious disease area, but even in the vaccine side, how do we actually get these to the clinics and to the kids that need them? And it's just a huge challenge to the imagination. Stockouts, just the vials, the volume of the cold chain, they come in big boxes packaged with elaborate labels which are designed for developed countries to market or brand certain products, which can't even fit into the space that we have available. I was in Mozambique, and when you are out and you're looking at some of the projects, you always find the heroes. And Margarida Messine in Mozambique is absolutely one of our heroes in terms of working in global health and addressing a problem which people underrate generally, but having huge impact. It's a group called Village Reach. And their simple solution is that the problem is that healthcare workers in a clinic are not busy looking at their stockroom and taking notes about how many drugs they have left. They're busy trying to deal with the large number of people coming into the clinic. So what typically happens is they don't put in a request to the central supplies on time, and then what happens is you have a stock out. And there's nothing more damaging to the healthcare delivery to have a mother come with a kid for a vaccine to be told, well, come back next month because we don't have any in stock. That is really damaging to the healthcare system reputation and improving coverage. So what Village Reach has said is that let's just push these things out. Let's not wait for healthcare workers to put in requisition. We're just going to push all the supplies out to the clinics. And they've been doing this in 5 provinces in Mozambique very effectively. In Maputo province, where they have 84 clinics, they have 2 guys and 2 trucks, and they have 1 reserve truck. And they cover those 84 clinics, and they've reduced the stockout rate to absolutely 0. And it's just a fantastic system. They've got a simple little form. They come over there, they check what's needed, they put in the supply, they go back, they've got a little computer back in Maputo, and they log things in a very effective, simple system. And Margarita has been central to maintaining a very tight control on the quality of that program. No reason why we couldn't expand that to other areas. IVAC, your center over here, held this important meeting for us. And these are the little things that make such a difference. And people sort of say, well, what does that got to do with innovation or technologies? The size and the shape of a vial that you store a vaccine in, well, it makes a big problem when you've got limited supply chain over here. So your attention to these kinds of details are exactly the things that we need in terms of having practical impact and applied solutions. We always come back to this issue of access and affordability. And in terms of some of the innovations I think that I'm most proud of that we have jumped in with are around some of the financial instruments that we've been able to put in place to incentivize, for instance, the developing country vaccine manufacturers. So whether it be the volume guarantees or the advanced market commitments, and now an increasing set of tools that we have, these PRIs, we have made equity investments in little startup companies, not with an intention of making any return on the investment, but so that we could actually tie up the intellectual property for the global health partners and for the global health community. And that company would then be able to develop its product further. There's some fascinating examples that we have. Chris, you've been involved with some of them. How do we get actually on this front? Here we have the DOVE program over here, which is around cholera. And I'd mentioned some of the issues with cholera already in terms of we have a very effective new vaccine, we just can't make enough of it. So we're in this sad but nevertheless essential exercise, and we talked with some of the groups around how we would do this. How do we prioritize the 2 million doses we have in the stockpile right now? That stockpile was put in place last year. The first dispensement was made actually into South Sudan very recently, so it took a while, but it was made proactively into the refugee camps in South Sudan to prevent cholera outbreaks. But how do we go beyond just outbreak reactive introduction of the vaccine into areas where cholera is endemic. For that, we'll certainly need more vaccine than the 2 million doses, and we have a lot of work ongoing in how we get that. But Dove has been an important partner for us in terms of thinking through those issues. This is what I was going to come to as well. There is, and there has been in the last couple of years, as particularly I think the faculty would be aware, not a good situation in terms of funding of research. And that's been the case particularly in the developed world. In global health, the economic downturn impacted us tremendously in terms of sources of overseas direct aid and being able to direct some of those resources into R&D for global health. So we were delighted when actually the Japanese government, in collaboration with 5 leading Japanese pharmaceutical companies and with ourselves as one of the partners, were able to really put in place, it's about $120 million new dollars into R&D for global health. And this is accessible. I mean, there are some constraints in terms of working with either these companies or their partners, but it's pretty broadly open. And our product development partners like Drugs for Neglected Diseases Initiative, Medicines for Malaria Ventures have jumped in over here and been able to utilize this as a new source of funding for R&D. You are very strong on the analytics side. I know this from all of your publications in the epidemiology space, and we ourselves have a very strong commitment over here. We've talked about this, but I wanted to give you just one current perspective of how this is important to us and how it's being actually deployed. So we talked about the polio endgame. And let's just focus on northern Nigeria, which has been a very difficult region for us to work in. One of the difficulties has been that we are implementing the program by these supplementary immunization activities. So we go in with a certain number, it could be 3, 4, 6, 7 supplementary campaigns on a state-by-state basis in northern Nigeria based on the risk that we are putting to an outbreak arising from those states. And that risk is actually fairly high, but it is differentiated, so the strategy is not uniform in each state. There is a very poor routine immunization coverage in northern Nigeria. In some places it's down to single-digit percentages, which is not a good situation. And with the campaigns, when we first started to analyze them, there was a very variable quality. So it would be the case that there would be a lot of local diffusion of funds in terms of groups would be giving money to close friends, and essentially the campaign would be somewhat of an inside job to the extent that there would not be an effective delivery of vaccines. And you'd look at people would, the supplies would disappear, but there were not good quality checks in the system. So one of the solutions was to implement this GIS mapping of the actual teams. And the quality, now using mostly local people to implement it, has been dramatically improved. So the teams carry these GIS monitors, and then we can map. These were 3 days of campaigns, the different colors, the yellow, the black circled green, and the green. Typically you have the vaccination day, and then you have the mop-up campaigns to fill in where you didn't reach. And we were able to track the group that's monitoring this, which is largely UNICEF and WHO. The GPI program, we're able to track exactly where these immunization supplemental teams are going and see that they reach every village, and we can highlight the parts and the hamlets that they do not actually hit. With this GIS mapping, when they were doing micro-planning before this, maybe a third in some cases, a quarter, a third of the hamlets were not even on the standard maps. So in some cases, not even an intentional omission of an area, but in the standard map, you wouldn't even find these villages. With this, we've been able to, I think, tremendously improve the quality of these GIS of the SIA campaigns. This work on pneumonia etiology, which is known as the PERCH study, continues to generate very useful data for us. So I've said that pneumonia is the leading cause of death in under 5-year-old kids. And just the enterprise of saying, well, let's go and study the etiology of pneumonia around the world, in the developing world, is, I would say, 20 years ago, people said, well, that's fantastic. There's diverse etiologies, there are viral causes, bacterial causes. How is that going to happen? And you have laboratories with varying capabilities in all of these countries, different standards, assays. That's never going to happen. So I think that in terms of defining what is the high point in terms of a data collection, quality, standardization, how you think through what is actually going to happen with the samples as they move from the particular collection in the field into the laboratories and into analysis, PERCH really defines that high point in data quality. And some of our other networks, I'm not going to mention more publicly exactly which ones, but some of our other networks which do not have this data quality, we've basically said to them, could you go and speak please to the PERCH investigators and try and replicate a little bit of their quality in some of your trials, because we are not seeing that we can usefully use this kind of data. Your contributions in terms of this aspect of what I like to think about, you have to really understand the state of the world in a very real primary data sense to be able to design useful impacts. We have a lot of analytics that we run on very sparse data, and then we argue about the outcomes of the estimates, which have got these wide confidence bounds. We were talking about typhoid at one of the earlier meetings. Well, if you look at the global burden of disease in 2010, the confidence bounds of death from typhoid are between about 200,000 and 600,000. So somewhere between being an important cause of death at 200,000 to being something that we should all be jumping on right now at 600,000. That's what our estimate of the typhoid mortality burden is. And unless we get that straight, how would we know, and how would the people who are trying to fund useful interventions know where to put their resources in a planned way? How do we use this data? Well, we actually do look at it in the sense of, for everything that people propose, we look at the cost effectiveness. And let me just explain a little bit about this bubble chart as you see it emerge over here. So on the vertical axis, it's dollars per disability and death averted, where at $100, something is really cost effective. And you see that we've got the benchmarks over there, bed nets for malaria. And then we have something which is even cost saving, surgical male circumcision, because that actually avoids HIV infection. As I've said, very effective. And that avoids the costs of opportunistic infections, hospitalization. So everything that we do, we actually contrast to the benchmarks. And the question for us is, do we go and invest in, let's say, a hookworm vaccine? Down over here, you see the small little dot, which many people pointed out to us. Do you go and invest a lot of money in the hookworm vaccine? Or do you actually provide families with a third bed net in Zambia, where 2 bed nets have been very effective, and there's some data which shows that even provision of a third bed net would be even more effective. So these are just the very difficult resource trade-offs that we try and make. We don't use this as some rigid, of course, the confidence bounds on each of these. The actual bubble size is the total burden, and I've explained what the meaning is on the vertical axis. The confidence bounds around this are huge, but it does stop us from doing things which don't make sense. So for instance, we've deprioritized the hookworm vaccine based on the fact that it really, versus what else we could do, giving out drugs, albendazole, to kids in endemic areas, hookworm areas, is pretty effective. And if the vaccine would have to be absolutely miraculous to be more effective than that. So we've deprioritized that based on this kind of analysis. Our partnership with you is one of the many partnerships that we have. And I love this partnership wall that we've been developing. Every time I speak, the font gets a little bit smaller, so you have to really look with a microscope. But you can just see that we've lined up the partnerships we have with you, which are huge and growing, and the partnership wall of people who are excited about global health and want to participate and want to help out in some way has just been an amazement to me. Oh, you locked that slide. You didn't want to move to this important slide, which is the institute that you have here around population family planning. We are heading to the goal which Melinda had proposed as part of the summit last year, the 2020 goal to put 120 women currently not accessing family planning on family planning. And that's going to be a great challenge, but there's a very definitive plan for that. And the institute over here is a central part of us understanding how that's going to happen with the mix of contraceptive technologies that I think women want and deserve. This is an implant introduction over here. We've been working on a generic version of that implant, which has got very good quality, but comes at a fraction of the dose. Ultimately, we're moving down to contraception being available at roughly $1 a year. And when you get down to that type of cost implementation, why we couldn't deliver this and make the 120 million would boggle the mind. I want to step into an element now where we'll have hopefully a chance to have some discussion and dialogue. And people have said, how do we interact with Gates, and what can we do with you, and how do we get involved in your programs? And how do we even potentially have an opportunity to join you for a while? So I wanted to talk now about how you can get directly involved with our programs in a very practical way. And then hear from you general questions, but also maybe further on this. Grand Challenges has really, to my mind, been one of the enterprises that has ignited energy around many global health issues. And we see participation from countries that I would not have imagined would jump in, from Brazil now, most recently, India as well. Canada and the US really were in, I guess, from the get-go in terms of Grand Challenges. And Grand Challenges has got a number of different flavors. So there's the Grand Challenges Exploration. We make about, well, the 100,000 grants, and we make 60 plus of those every year. Those are often being, in the countries that you see over here, are matched by additional funding, but those are just seed grants. You submit a 2-page proposal with any idea, and I've seen some really amazing ideas. The last one we ran was improve the condom, which succeeded the one we ran before that. We haven't released all the ideas yet. I can tell you, I said, well, how are they going to improve the condom? Well, there are a lot of creative ideas around that. And the one before that was the toilet 2.0. And you may have seen in the news that there's a toilet fair in Delhi right now around exactly this enterprise with our partners in India. So Grand Challenges, from the exploration point of view, if you have a great idea, 2 pages, send it to us, and you're a candidate to get seed funding to just see if this works. We have the larger Grand Challenges enterprise, and actually, we have the, coming up in October, we'll have the Grand Challenges meeting, which is a big meeting of people who participate in Grand Challenges in Seattle. The last meeting last year was down in Rio, actually, where we'll announce what we're going to do going forward. We're going to have a Grand Challenges, as we call it, everybody calls these things 2.0. So it will be slightly different, but it's going to be a big investment, and we hope to attract a lot of partners, whether it be from the US government or outside, to participate with us and maybe a scale-up in our Grand Challenges enterprise. So aside from the small seed funding, there are also fairly substantial grants that we make around particular topics, which come to us from both inside and outside. And people might say, well, we're interested in, it could be really improving the game in terms of TB diagnostics, or it could be malaria diagnostics. So let's put out an RFP with a substantial amount of funding over multiple years and see if we can attract some really interesting proposals. So that we will absolutely continue to invest in. And you'll see that coming out probably in October this year, what the format of that is. So these are 2 very viable mechanisms, I think, both from people early in their careers who've got some great seed ideas. And we've had high school students who've put in ideas for the Grand Challenges exploration, and some of those have been funded. So this is one that's running right now, actually. I just put it up here. Measuring fetal and infant brain development, which has really vexed us. So we would like to nail down this linkage between nutrition, cognitive development, nutrition and all the other elements around gut dysfunction, the microbiome, and cognitive development. And I guess we've run out of our own ideas, so we put out the challenge to folks out there. What do you think? And I've already seen some pretty unusual devices and some pretty unusual proposals on this, but this remains open right now. People have been joining us, and people from Hopkins have been joining us, both at our sort of senior levels. We've welcomed a number of your esteemed faculty to our home. But we've introduced recently, beyond the internships, which we've had for a couple of years, a Gates Fellows program, where people come to us for a couple of years and they actually work as program officers at Gates. Luca Passerini, sitting in the rear over there in the middle, was fairly recently graduated here from a program at Hopkins, and he joined us last year. And this is the current group of fellows that we have. This is a program that we're going to expand. I absolutely, well, one thing I've said, I'm not sure if there are too many people from the management consultancy arena over here, probably not. But I see a lot of people with great experiences looking for opportunities, and it's amazing now from many different disciplines, MPH disciplines, from PhD programs, they think that the pinnacle of achievement is to go into management consultancy. And then what happens is they go and work for one of the big management consultants who we may work with as a partner, and then they come back to us as a junior associate of the management consultancy, and we then pay a huge premium to have them work and train with us. And what we said is, let's short circuit that. Just come and work for us directly. You don't have to go and work for one of these. And you'd have a much more interesting life, and I think much greater prospects if you do that. So that was all I wanted to go through, and I'm not sure what our timing is, but do we have time for?
So we have I think till about 20 after.
Okay.
And I would let me just go to the mic. And because we have an overflow room and it's being recorded, I'll ask people to use the microphone. So we have 2 microphones set up, and so people who have questions, please come to the mic. And while they're doing that, let me just say thank you for a great talk. And I was very happy. I was very happy to see that you started talking, when you started talking about diseases, you started talking about TB, because as Dr. Barker reminded me at the beginning of today's talk, today is World TB Day. So a third of the people in the world are infected with TB, and so it's an important initiative for the Gates Foundation. So let me ask, I know people have burning issues, or they want to argue, or they, so, yeah. So Clive, can we get a microphone to Clive here? Oh, Luke has a, oh yeah, so, no, okay, so Clive.
Thank you very much indeed. One of the things that, my name's Clive Schiff, and I'm also from your neighborhood. One of the points that you were talking about at the beginning was very much the inability of local health systems to function. In the malaria world, one of the most important documents that was published was a thing called The Tomorrow of Malaria, which is by Socrates Litzios. And what he said was that you can't control malaria if you don't have a health infrastructure. So this needs to be done first. So many problems would be solved, or would be more easy to solve if there were good health infrastructures. So to what extent do you contemplate including upgrading of the health system getting some political support from the country to support these interventions that you're trying to do? Because in the long run, I don't see these interventions as being sustainable.
No, that's an important question, and one that people ask a lot of us is, it's a little bit to that innovation question. What are you doing to actually improve fundamental healthcare systems? Because then you could think less about these new interventions or new technologies, and you could just effectively deploy what we have right now. And it's a little bit of a complex answer in that I do fundamentally believe that the basic infrastructure, building buildings, building clinics, the major training of healthcare individuals, if this is not coming from the countries directly, or the countries effectively deploying aid that they may receive, then it's difficult to see how that's going to be sustainable. On the other hand, when it comes down to questions such as planning of distribution of resources, whether it's a question of, as we've done, let's say in Ethiopia, we have got a very large technical support unit around planning agriculture with the Department of Agriculture in Ethiopia. We have a technical support unit at the Ministry of Health in Kenya, which actually is a very interesting transfer of knowledge. It was set up by the Avahan HIV program in India. Our Avahan program put a small technical unit to think about the better distribution of antiretrovirals and resources to the different regions in Kenya, which was happening on a very homogeneous basis without thinking about the different aspects in the different areas. So that kind of planning and thinking about how does one upgrade a supply chain? How does one appropriately introduce some cell phone technology, which is now quite pervasive in parts of the developing world, more effectively? How does one use M-Pesa, the banking systems, to incentivize local farmers, for instance, smallhold farmers? So there's a lot of this work around planning, analysis, understanding the problem, data collections that we're very much involved with. And certainly on the advocacy front, the problem that I see is the Ministry of Health is often quite weak within the system of ministries. It's the Ministry of Finance that holds the keys to the realm over there. We had a recent experience in South Africa where we've been working with the Ministry of Health and the Medical Research Council to think about an investment on capacity building over there. And we got essentially bogged down because the Ministry of Health said, we've got no more budget. That's it, it's run out. But we were able to actually involve the Ministry of Finance, and suddenly things opened up. So that kind of advocacy and I would say planning, strategy, input is where we see our role. But the basic fundamental bricks and mortar, I think, for a sustainable solution have to come from these countries.
Well, thank you very much. It's been a lot of fun for me. I'm Luke McDonald. I'm a scientist in environmental health sciences, and I'm also with the Johns Hopkins Water Institute. And I'll be quick, but just as an aside, we are working with the Institute, the Gates Institute here, on the performance monitoring and accountability, the mobile survey where we're tracking family planning access, and it's just been a fantastic opportunity to collaborate across disciplines, so thank you for that. But my question is this. A lot of the problems that you spoke about are environmental problems, environmental health problems, and I just wondered if you could speak a little bit more about how you're addressing that aspect of it. I heard a lot about vaccines and so on, but I'd like to see where the Institute Foundation is going. So, and I'll take my answer from my seat.
Okay, great. I mean, you allude to something which is, I think, absolutely central to the way that we're trying to operate, which is an integration across these various dimensions of the problem. And water, sanitation, hygiene, if one's talking about enteric diarrheal disease, then, absent some miracle, vaccine, and even with that, the pressure of infection and the state of the environment is something which has got to be integral to the solution. So when we've been looking at, for instance, the introduction of the same cholera vaccine that I was talking about in Bangladesh, we included a wash component around improved water, good water quality source, and hand washing as part of the introduction. We have to see what the evidence was generated around that, but the fortunate thing that we have at Gates, and what I've seen, is that because we have these many different groups, we have the WASH group, we have the AG group. When you're talking about nutrition in mothers or in infants, you can't be talking about that without talking to the agricultural group. So we have had a system, I think that, just reflecting on our own position, where we've been within these categories: agriculture, water, sanitation, hygiene, some of the health areas, too siloed. The situation of the last 2 years, particularly with Chris Elias coming on board, has been fantastic in terms of fostering a lot more connection between these areas. You probably can see it better from outside. So if you still think that there's a lack of connection, that we're not thinking adequately about the WASH sanitation components of a diarrheal disease program, then let us know.
Just want to make sure. Do you want to ask a question? You're handling the mic. Okay. So, David?
Hi, I'm David Bishai. I'm one of the health economists on our faculty, and I really have enjoyed this talk immensely. I wanted to follow up your answer to Clive Schiff. Yes, we realize that it has to come from the country. But one of the most inspiring talks I've ever heard was from my colleague Carl Taylor, who passed away, unfortunately, several years ago. And Carl's famous quote is that there are no universal solutions, but there are universal approaches to finding a local solution. And what Carl was telling us, and what he taught for so many years, is that yes, you actually can. There is an innovation that can be put in place that helps local communities find solutions. You don't have to wait for the government to wake up. And Carl documented this extensively, and his work in the Seed Scale program around the world showed us that you don't just have to wait for a great government to be there. You can actually practice public health to put in partnership the experts like us, the community and the politicians, and guess what? They will make progress. And so I think that the Gates Foundation doesn't have to just wait. That if you go back to your Carl Taylor and read up, I think you'd be a lot more inspired and more optimistic.
That's a good caution. I did see one example of this, which, and this is one area we could jump in the HIV area. We've been doing some work on the effectiveness of antiretroviral delivery in Kenya and Uganda. And the interesting thing we found was that if you look very locally and you take the best clinics on a set of measures like viral load suppression, mortality in their local catchment area, and you map them on what you could call the efficient frontier versus other clinics, you find that there are these excellent local clinics. Actually, they're doing very well, but then most are not. And if we went through the exercise, what if we were able to move the ones who are not just up to what the local best practice clinics are doing, we would be able to increase coverage by 50% of antiretrovirals without increasing funding. And that's sort of an astounding notion. So we don't have to go down to the Western Cape, and it's got good infrastructure, and it's got an interesting system, adherence clubs and all kinds of things over there, and say, go up to Uganda and say, well, you've got to do what the Western Cape is doing. We can say, well, just go to your clinic 10 miles away. Just watch what they're doing. On these measures, they're doing an excellent job with the same problems that you have. So I think there's a lot to what you say over there.
Kate?
Trevor, thanks for a great talk, and I'm sure you've stimulated a lot of discussion that's going to happen outside of this room. I have two quick questions for you. This is clearly a school of public health, and so my first question is about capacity building. We have students from all around the world, but capacity building happens in ways other than sitting in classrooms, either through distance learning or sitting here. So I wonder if you could talk a little bit about how the Gates Foundation views capacity building and the role that institutions like Hopkins should play in the future around capacity building. And my second question is around resources. And the specific question is, the Gates Foundation has enormous resources and has been very generous in the distribution of those resources to issues of concern to the foundation and mutual concern to institutions like ours. Has the foundation had any concerns and done any analysis on whether or not the presence of the foundation in this space has had an impact on other people putting resources in, other institutions putting resources in? And if so, how to mitigate that problem?
With an expectation that maybe it was negative or not?
Yeah.
I guess I was asking about any analysis on it. If there was a negative impact, how do you mitigate that?
Right. So, Kate, I'll come back to your capacity building question, but let me just take this one on. So I don't have an analysis across the board of what our impact has been maybe on inhibiting, because I've been focused, and I think our group's been focused on how could we put new coalitions of funders together, like the GHIT, the Japanese government. I mean, that's amazing to me that thing moved in about 6 months, and I've never seen the Japanese government move so quickly on that. This new, on such an international effort, this new funding I've talked about, or this new initiative around the neglected infectious disease, which we'll talk about, we decided to put in some seed funding, and we went to a number of the other potential funding sources. And suddenly, our funding was multiplied by 3-4-fold. So what I've been encouraged by is that when we are able to put in the Medical Research Council funding that we made in January in South Africa, that was then matched about 4 to 5-fold by the Ministry of Finance. So I think I've just been looking at these examples where we've been able to multiply and leverage our seed funding and get others to invest. But you ask a good question. I mean, I haven't looked at the issue of have we inhibited others from funding. I know other foundations have said to me that they somehow don't want to be dwarfed by us. They want their own time in the limelight, and I'm totally happy to take a step back and let them run with certain ventures. So they have a sense that they need to be, I think in some cases, orthogonal to us. So they haven't wanted to fund the same set of topics that we're funding. And there's been this desire to be orthogonal. That's information I can give you on that. The capacity building is interesting and important because at Hopkins you have such a great international group of people that are receiving fantastic training over here. What I am focused on and have some concern about is how do we create the conditions back in your home countries so that it's really attractive for you. I mean, this is a wonderful environment. If I were you, I'd be looking and say, well, how do I stay at Hopkins? It's great to do science over here. I have this international community. I'll have to stay here forever. I had that thought when I was at Oxford at one stage, I can stay here forever. But that didn't happen. So how do we not have that happen? And how do we, if somebody is well-trained and they have some ideas, they also want the capabilities to be able to execute on those ideas and do real work. So we have had a focus on where we've seen opportunities, whether it be in Mozambique or in India or in South Africa, to actually put some funding into science in those countries. Why would you have all of the work on HIV and TB be going on in the US and Europe, essentially, when there's such a huge local problem and you have such opportunities in terms of, we don't have models, we have models, but you can question their utility in some cases. But we have these populations who are really experiencing, these epidemics. Why wouldn't you be studying them locally? And it's not a question that you can just ship samples over to Seattle or that we can try and orchestrate the world from Seattle. You've got to work locally. So I'm interested in that second part of capacity building.
So I would say we are too. And and we have a track record of that. I see Chris Byer out there who ran the Fogarty training grant. We had over, I think, close to 1,000 trainees. 91% went back to the country. And we do that by building collaborations and building professional opportunities. So I think we're with you. I'm sure Kate is too, 100%. So let's have the last question, okay?
Thank you very much for your great talk. I'm Ahmed Hassoun from Iraq. I'm a summer scholar at the MPH program. Can you hear me now?
Yeah.
Yep.
I'm Ahmed Hassoun I'm a summer scholar from Iraq. I'm in the MPH program here. Your foundation and our school have been doing a great job in saving millions of lives at childhood and prevent childhood death. But unfortunately, we are letting them towards the chronic diseases in the future, especially in developing countries with a great burden of heart diseases, diabetes, obesity, and cancer. Do you envision any role for Bill and Melinda Gates Foundation in addressing these topics in the future?
It is one of our intense debates. We were just having it in our strategy reviews with the co-chairs, with Bill and Melinda. How invested do we get and transition to non-communicable diseases as well as part of our mandate? I didn't show the numbers here, but I think the global burden still shows that in the areas that we are most focused on, sub-Saharan Africa, the infectious disease entities that we're working on remain the major burden. And from a little bit of not wanting to jump in where everybody else is, there's a huge investment, obviously, in developed countries. There's a huge investment in the private sector in addressing these non-communicable diseases. For the time being, we're very focused on completing the mission we have around infectious disease. But there are some important intersections, I think, we have where we can contribute a lot. It's believed increasingly that many of the risks for developing diabetes, metabolic disease are established very early, if not neonatally or in infancy, maybe even in utero. And we have a huge investment in research. We may be one of the biggest investors in research around the microbiome, actually, and trying to understand many of the issues around childhood, in utero, maternal, prenatal, nutrition, which define a much better circumstance. And to the extent that it would be great, obviously we focused on saving these kids early in their lives. It's not a good situation if we then flip them over, and we've seen the transition, how rapidly it's happening, that it seems like the populations that are in transition economically are those most at risk from these metabolic disorders. So we are focused, we have a certain focus on that problem from the maternal and infant side of things. How do we not generate tomorrow's problems at the same time that we're solving the problems of today?
Well, unfortunately, there's going to be 250 students who are going to be coming into this room in a few minutes, so we have to end. But I want to, I'm sure, voice everybody's thoughts. Thanks for what you do. Thanks for the Gates Foundation. Thanks for spending time with us, and thanks for your insights.
So yeah, so our view is we want to